I'm Yulia. I'm one of the TAs for Psych 337, and I'm going to be doing the review session today. Just going to wait a little bit for more people to join us. Okay. Hi, guys. So I have quite a bit of questions. I'm going to try to get through as many as I can. Okay, so question 1 is it possible to be diagnosed with antisocial PD without having a diagnosis of conduct disorder in childhood, or is it necessary to have traits of conduct disorder in childhood? So the short answer is it's not possible to be diagnosed with antisocial without having conduct disorder traits in childhood. So if we look at the DSM-5 criteria for antisocial, you see that one of the criterion for criterion C is for this diagnosis to be given, the individual must be at least 18 years and must have had a history of some symptoms of conduct disorder before the age of 15 years. So it is necessary to have traits of conduct disorder in childhood. And I had another question that was similar to this, so I'm just going to put them both into one and talk about them together. So the next question was, can you clarify the relationship between conduct disorder and antisocial personality disorder? Is it a precursor, a risk factor, etc.? Is it present in both or just one? So I'm just going to talk about conduct disorder for a bit. It's a disorder generally diagnosed in childhood. And it basically consists of a repetitive pattern of behavior where the kid violates the rights of others or violates rules. This can be manifested in, for instance, aggression to people and animals. So the kid might bully people, they might initiate physical fights. The kid might have been physically cruel to people or animals. They might also destroy people's property, break into people's houses, lying to obtain goods or favors. They might also seriously violate rules. So, for instance, staying out at night despite the fact that their parents tell them that they can't, or being truant from school. So those are the kinds of things that may get a child a diagnosis of conduct disorder. Also, the disturbance must cause significant impairment, and if the individual is 18 years or older, if they meet criteria for antisocial, they would get the diagnosis of antisocial, no longer conduct disorder. So that's the relationship between conduct disorder and antisocial. Basically, you need to have seen evidence that the kid displayed these conduct disorder traits before the age of 15 in order to get the diagnosis of antisocial. And this is sort of to emphasize the fact that these two things are very related with one another. So it's not like generally antisocial personality disorder doesn't just develop like that out of nowhere. Generally, it develops sort of from childhood and kind of persists, may or may not persist into adulthood. Now, kids with conduct disorder don't necessarily develop antisocial personality disorder. So it's not like if a kid gets a diagnosis of conduct disorder in childhood, they will automatically go on to get a diagnosis of antisocial. But everyone who is diagnosed with antisocial personality disorder must have displayed symptoms or characteristics of conduct disorder before the age of 15. Okay, so it is a precursor to antisocial personality disorder. Okay. I think that question also asked about psychopathology. Oh, never mind. Also, something that's interesting about conduct disorder is that you can specify if the child has limited prosocial emotions, and this looks like psychopathy. So, like a bit of psychopathy and antisocial. So, for instance, you can like the kid who gets the specifier shows like a lack of remorse or guilt, a lack of empathy, and shallow and deficient affect. So that's kind of something interesting about conduct disorder. And again, like underscores this concept that conduct disorder and antisocial are very closely related, and people with antisocial personality disorder display these traits in childhood as well. Okay, I've kind of grouped together your questions based on themes so that I'm not going back and forth between different themes. So the next question I'm going to answer is, what does the item parasitic lifestyle consist of in Robert Hare's psychopathy checklist? So a parasitic lifestyle basically means that psychopaths use people and feed off of them. So they might be dependent on people for things like money or their living arrangement. They may manipulate and exploit people in their lives to get them to give them money and support them. Psychopaths might not want to work and have responsibilities, so they might leech off of other people. They might use people, but they don't actually care about them. They're using them for their own personal gain. So for instance, if someone is dating a psychopath, the psychopath may move in with her and then steal her money, not do any work or housework, and then leave without giving any warning that they're done using her. So that's what is sort of meant by a parasitic lifestyle. It's characterized by leeching off of other people for things like money and living arrangements. Okay, the next question, let's see how we're doing. Okay. Next question is about criticisms of the psychopathy checklist. The question is, Dr. Weinberg mentioned in class that one of the criticism of Hare's psychopathy checklist is that it doesn't address the lack of anxiety or lack of empathy that a lot of people feel is central to psychopathy. However, item 7, shallow affect, and 8, callous lack of empathy, are found on the list and load onto factor 1, emotion, interpersonal features. How does this not address the issues brought up in the criticism? So let's look at that like bit by bit. Let's talk about shallow affect first. So item 7 on the psychopathy checklist is shallow affect. So if you're going to give someone a high score on this item, they need to display shallow affect. So their emotions don't run very deep. It's all very surface level, and they don't seem to actually be feeling a lot of the emotions. So shallow affect is not the same as a lack of anxiety. They're not equivalent terms. A lack of anxiety is a very specific absence of reactivity to danger. So psychopaths, so this is different from shallow affect because that's sort of like a global thing where like globally you have these superficial emotions where you don't feel feelings deeply and you have these impoverished affective reactions for like all emotions. But lack of anxiety is very, very specific to anxiety. So that's why this criticism was brought up. This shallow affect item is too broad. It doesn't specifically look at the lack of anxiety that psychopaths sometimes display. And as for item 8, callous lack of empathy. So this refers to a person disregarding the feelings of others and just being completely unconcerned with other people's feelings. The individual described as having this callous lack of empathy is cold and uncaring, and they appear to be more concerned with like the effects of his or her actions on himself and is very unconcerned about how their actions might affect other people, even if they are greatly harming other people. So that's what callous lack of empathy is. But itself is a much more multifaceted construct. So the PCL might look specifically at callous lack of empathy, but empathy is a broad construct that can't really be addressed just by looking for callous lack of empathy. So empathy can involve very many things. For instance, if someone is high in affective empathy, that means that they have a great capacity to feel other people's emotions. But if they have high cognitive empathy, that means that they're able to understand the way that people think. And so understanding other people's frames of mind. Obviously, you can be high in both affective and cognitive empathy, etc. So the Hare's checklist doesn't address this part of empathy at all. It doesn't ask people to look at the levels of affective empathy or cognitive empathy when they're assessing someone who they think might be a psychopath. So, for instance, it might be the case that psychopaths are unable to feel other people's emotions, but they are able to get into people's heads and understand their frames of mind. But the checklist doesn't address this at all. So that's kind of how, that's why the checklist has been criticized in this way. Okay, next question is about the neural of startle. Question is, what is the function of the nucleus reticularis pontis caudalis and the cochlear root neurons? Dr. Weinberg doesn't go over this during her lecture. Okay, so let's break that down a little bit. Cochlear root neurons are the first central neurons that receive input when sound hits your ears. So they're lined along the cochlea inside your ears, and basically what happens is the sound comes in, it hits your eardrums, and then the information from the sound is captured by these cochlear root neurons that are along the cochlea, and then this information about the sound that you're hearing is transmitted via the cochlear nerve into the brain. So that's cochlear root neurons. And then the other part of the question was the caudal-pontine reticular nucleus. It's involved in head movement. So some neurons fire when you're chewing or grinding your teeth during your sleep, and so on. So the caudal-pontine reticular nucleus, it receives signal of noise from cochlear root neurons and relays it into facial and spinal motor neurons. And these neurons cause the reflex blink, for instance, or sorry, the blink that indicates that a startle reflex is happening. Okay, so that's basically what it is. The cochlear root neurons pick up sound, they relay this information to the caudal pontine reticular nucleus, and then this relays the information onto facial and spinal motor neurons that cause the startle reflex to show on your face. Okay. So next question is about Patrick, Bradley, and Long, the study on fear potentiated response, and when they're comparing like individuals with antisocial personality disorder, psychopathy, and then neither. So the question is, what was the difference between the pure antisocial and psychopaths? Are pure antisocial people who met criteria for antisocial personality disorder but not psychopathy? Or how was that distinction made? So in the study, you have two different groups. The purely antisocial group are people with antisocial personality disorder. So they're purely antisocial and they don't have the affective deficits that psychopaths have. So it's people with antisocial that are not psychopaths and they only have antisocial behaviors. So that's the difference between the two groups. And then the psychopath group are individuals who are high on the psychopathy checklist. Okay, next question is about etiology of antisocial behaviors. How would genes increase the likelihood for a child's exposure to environment risk factors? Okay. So I'm gonna give an example of this. I think that is the best way to illustrate it. So let's take the example of aggression. So aggression is very genetically influenced. It's highly heritable. It runs in families, and it's very, very genetic. So to answer the question, for instance, if the kid has two aggressive parents, then that child gets genes for aggression from his parents. But if the child has two aggressive parents and he grows up in a house with them, that means that he's also growing up in a house with two aggressive parents, which might be an environmental risk factor as well, because the two aggressive parents may maltreat the child. Child maltreatment is a risk factor for conduct disorder, and as we know by now, you need to display conduct disorder characteristics to get a diagnosis of antisocial personality disorder later. So basically, child maltreatment puts people at risk for antisocial personality disorder. So in this case, the kid has genes for aggression, And that also increases the likelihood of exposure to aggressive behavior in the home because the parents who raise the kid also gave the kid their genes, and the parents who are raising the kid are also aggressive. So that's one example that I can think of. And on the flip side, having parents who are not aggressive would mean that those parents give the kid, will likely give the child genes that don't increase likelihood of aggression. And having parents who are not aggressive also means that the kid is not exposed to an aggressive or abusive environment. So that's like the opposite of the first example that I gave. So that's one example of how genes can increase the likelihood of a child's exposure to environmental risk factors. Also, if a child has a genetic predisposition for aggression, he might seek out situations in which he can be aggressive and let the aggression out. So, for instance, the kid might start fights a lot. He might find himself hanging out with people who start fights a lot. So that could also increase the likelihood for the child's exposure to environmental risk factors. He might find himself in violent neighborhoods. And as we know, living in a violent neighborhood with lots of violence is also a risk factor for antisocial behavior. So that's another way that that could happen. Okay, the second part of this question was, is the MAOA gene as a diathesis related to the genetic pathway of genes moderating the susceptibility to environmental risk factors? So I'm just going to talk about the study that Dr. Weinberg presented addressing this, and hopefully that answers the question. So most maltreated kids don't go on to engage in criminal behavior, but as I mentioned earlier, and as Dr. Weinberg mentioned in class, maltreatment is a risk factor for conduct disorder. So being maltreated as a child puts you at risk for developing conduct disorder. But there's a different susceptibility to experience of maltreatment, and this depends on your genetics. So the Caspi et al. Study indicated that activity of MAOA and interaction of maltreatment both have effects on antisocial behavior. So at levels of no maltreatment and levels of very low maltreatment, there's similar antisocial behavior levels in kids with high and low levels of MAOA activity. But when we look at kids who have experienced severe maltreatment, having low MAOA predicts much more antisocial behavior. So just as a recap, having low MAOA means that there's like less degradation of serotonin, dopamine, and possibly norepinephrine. And all of this is associated with aggression. So if you have low MAOA, you tend to be more aggressive. So at levels of, so if we're looking at children with severe maltreatment, these kids who have low MAOA have much more antisocial behaviors. So this indicates that you need both severe abuse and also the genetic predisposition to develop antisocial behaviors, and you need the combination of the two. So it's an interaction between those two factors. So your antisocial behavior depends on how much abuse you experience and also the level of the MAOA gene, and that'll get you the different amount of antisocial behavior. So it does depend. So your development of antisocial behavior does depend on this gene and how it interacts with maltreatment and experience of maltreatment. Okay, the next question is about personality disorders. The question is, criterion F requires that the behavioral patterns exhibited by the individual are not the result of another medical condition. However, one of the personality disorders listed in the DSM-5 is personality change due to another medical condition, which is judged to be due to the direct physiological effects of a medication condition. Is this personality disorder an exception to criterion F, or is there an actual distinction between these two concepts? Okay, so to answer this, I'm gonna talk about what the DSM says. So the short answer is yes, this personality disorder is different. So the DSM says that in general, for personality disorders as a whole, the enduring pattern that you see, so their behavior, is not attributable to the physiological effects of a substance or another medical condition. But also in the DSM, there's this category, personality change due to another medical condition. And for a diagnosis of this personality disorder, there must be evidence from the history, physical exam, or lab findings that the personality change that you see in the person is the direct physiological consequence of another medical condition. Okay, so this clearly goes against the general criterion F for most personality disorders, because in this case, the change is attributable to the physiological consequence of another medical condition. And this personality disorder, if you look at it in the DSM, it does not have criterion F. So yes, this is an exception to criterion F. A criterion F does not apply here. Okay, now moving on to OCD. So the question is, criterion A in OCD describes obsessions as consisting of intrusive and unwanted thoughts that cause distress in most individuals. Criterion B describes the obsession as either time-consuming, distressing, or impairing. Is it possible for someone to be diagnosed with OCD without actually experiencing the distress? So let's look at the DSM criteria. So the criterion A says that you need obsessions, compulsions, or both. And obsessions are defined by recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and that most individuals cause most individuals marked anxiety or distress. So, I mean, the language there, most individuals experience marked anxiety or distress, like it's not all, right? So in that, like you don't need distress here, theoretically. The next thing that you need for obsessions is that individuals attempt to ignore or suppress the thoughts, urges, or to neutralize them with some other thought or action. So again, like you don't need anxiety or distress for this either. Now, for compulsions, compulsions are defined by repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. Again, there's no requirement of distress for this. The second sort of criterion that you have to hit for compulsions is the behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or in preventing some dreaded event or situation. So again, this is kind of an either or scenario. The behaviors might be aimed at preventing or reducing anxiety or distress, and in most cases, I would guess that they are, but you do have that caveat, or preventing some dreaded event or situation. So again, theoretically, this criterion doesn't require distress as well. And then criterion B says that the obsessions or compulsions are time-consuming, so they take more than an hour a day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So again, this is an either-or scenario where the obsessions or compulsions might be time-consuming, and or they might cause clinically significant distress or impairment. So theoretically, based on the language and the wording of the criteria for OCD, it is possible for someone to get a diagnosis without the distress, but I don't know how often that actually happens in real life, because generally OCD is distressing, right? Like the thoughts that people get are generally experienced with marked anxiety or distress. And I mean, the A1 criterion highlights this too. Most individuals experience a lot of anxiety or distress during these images. A lot of pages that pop into their heads is very disturbing, and they want to get rid of them. So that's often a lot of the motivation behind the compulsions. They want to reduce the anxiety or reduce the distress or prevent it, prevent that anxiety that they experience when they experience the thoughts. So theoretically, yeah, it is possible to get the diagnosis without the distress, because for the obsession, someone could just experience the obsession as intrusive and unwanted without necessarily having it cause a lot of anxiety. And then they might attempt to ignore or suppress the thoughts. And then for compulsions, they might have repetitive behaviors that they're driven to perform, and the behaviors might be intended to prevent some dreaded event or situation instead of aimed at preventing or reducing anxiety or distress. So theoretically, it is possible. And also for criterion B, the obsessions or compulsions are time consuming, but they might not necessarily cause clinically significant distress. So you need distress or impairment in this case. It's possible not to have distressing obsessions, and you can get the diagnosis theoretically without the distress, but I'm not sure how commonly you would see that in a clinical setting. Okay. Now let's talk about eating disorders. This question is about sociocultural risk factors for eating disorders. The fact that we are all exposed to media but don't all develop eating disorders is an example of the diathesis stress model. Would the diathesis be the media exposure and the stress be other factors like personality combined with the diathesis? I guess my question is, what would be the stress in the situation? Okay. So not quite. A diathesis is a vulnerability disorder. So a diathesis could be something like genes, early environment, personality characteristics that develop very early on when you're very young. So things like that are diatheses. And so the diathesis would not be media exposure in this case. So in the case of eating disorders, and in this case specifically, we learned in class that after puberty, genes account for 50% of the development of eating disorders. Ovarian hormones in particular contribute to this. So estradiol hormone increases in concentration following puberty for women, and this activates genetic regions that influence eating disorder development. So in this case, the diathesis for developing eating disorders is genes such as this. So genes for estradiol hormones, etc., just any genes related to the development of an eating disorder, that would be the diathesis in this scenario. So if you're genetically predisposed to developing eating disorders, then you would have this diathesis. So in this scenario, the stress can be, but if we're talking specifically about the scenario of media exposure, that is the stress in the scenario. So the media exposure is the stress. In the media, you could constantly be seeing images of very thin people. You might hear a lot of people in movies or TV shows talking about, how it's good to be skinny. I don't know, how skinny people are good looking. And this might be the stress. This might lead to an internalization of the thin ideal. You might develop this idea that you're not good enough, you need to be skinny in order to be accepted and to look good. So, and stress can be a lot of other things too. It can be like severe body dissatisfaction, something that just triggers it. So this stress, which in this case is exposure to media, sort of idolizing thin people or promoting the idea that being thin is good, this stress combined with the diathesis of, for instance, having genes that puts you at an increased risk of developing an eating disorder, that would be the diathesis. So that combination would place you at a higher risk of developing an eating disorder than someone who, for instance, experiences, movies, TV shows, etc., that promote this idea that being thin is good. So they do experience the exposure to media, but they don't have that genetic predisposition or that diathesis. They will not develop an eating disorder. So that's what Dr. Racine was talking about in her guest lecture. She was saying that we're all exposed to this media exposure that promotes the idea that being thin is good. So we all technically have that stress, but we don't all have that diathesis. So not all of us are walking around with eating disorders because not all of us are genetically predisposed to developing those eating disorders. Okay. The next question is, would it be possible to clarify the role of culture in eating disorders as mentioned in the last slide of the guest lecture? What are the cultural differences or similarities? How is culture a risk factor apart from the fact that more Caucasian women are diagnosed? Okay. So I'm going to recap a couple of the points that Dr. Racine made, but I'm not going to recap them all because she does a very good job of covering it in her lecture. So if you'd like to take another listen to that part, that might be helpful. But just briefly, shaming is not bound by culture. So overeating is found across cultures. There is, as the question mentions, an increased prevalence of eating disorders in white women. And among minorities, there are more eating disorder symptoms in people who have assimilated more to the dominant culture. So the more assimilated you are into the dominant culture, if you're a minority, you tend to have more eating disorder symptoms. So, and then this is just out of the DSM. So I don't think this was mentioned in lecture, but just for your curiosity, if you want to know how about cultural differences and whatever. The DSM says that anorexia is probably most prevalent in post-industrialized high-income countries like the US, European countries, Australia, New Zealand, and Japan. But its incidence in most low and middle income countries is uncertain, so we're not exactly sure. And the prevalence of anorexia appears comparatively low among Latinos, African Americans, and Asians in the US. However, there's a disclaimer here that mental health service usage among these populations with an eating disorder is significantly lower than, for instance, white women. So this might, the fact that there's a lower prevalence of eating disorders in these groups doesn't mean that there's an actual lower prevalence necessarily. It might reflect the fact that these cultures or these groups, individuals in these groups might tend to access mental health services a bit less. So it seems like they're getting the disorders less, when in fact they're getting the disorders at the same rate, but they're not accessing the services. And the DSM, according to the DSM, the rates of bulimia are roughly similar in most industrialized countries. So that's a bit more detail about cultural differences and similarities in eating disorders. Okay, this next question is about prevalence of opioid abuse. So the textbook says that heroin is the most commonly abused opioid. However, prescription opioids are also commonly abused, but the textbook and the lecture only provide stats for usage, not abuse, for prescription opioids. So prescription opioid usage is 8% in the last month. Should we conclude from this that heroin abuse is more prevalent than prescription opioid abuse? Okay, so it's likely the case that there are lots of prescription opioids being used, but not necessarily abused. And some people might still be concerned about this high usage. Personally, I don't know the stats for prescription opioid abuse, but the textbook does clearly say that heroin is the most commonly abused opioid. So I'm not sure if we can conclude what the difference is between heroin abuse and prescription opioid abuse, because I don't know what the stats are for abuse, and the textbook doesn't say that. But the textbook does say that heroin is the most commonly abused opioid. Hope that helps a little bit. Okay, the next question is about substance abuse disorder and alcohol use disorder. Since the professor has taught us that SUD and AUD separately, do you expect to see both terms used on the exam, or only the term SUD can be used since technically alcohol is a substance? So it will be clear on the exam what Dr. Weinberg is asking about in a question. I can't really say what's on the exam, but I can say that it will be clear to you what is being asked about. Okay. This is a question about eating disorders, specifically anorexia nervosa, binging and purging type. Question is, do binging and purging both have to be present for the subtype, or can consist of the diagnosis? So the question is, you only need one. As your textbook mentions, in order to get this sort of subtype label, during the last 3 months, the individual must have engaged in recurrent episodes of binge eating, or purging. So you can have both, or you can have either binging or purging. Okay, this is another question about eating disorders. The textbook mentions that one cannot be diagnosed with multiple eating disorders at once. However, I feel like it could be possible that someone has both purging disorder and night eating syndrome together, or night eating syndrome and bulimia nervosa. Okay. So night eating syndrome is in the other specified feeding or eating disorders section of the DSM. Basically, you can give someone a label of other specified eating disorder if the symptoms characteristics of an eating disorder do not meet the full criteria for any of the disorders in the eating disorders diagnostic class. So you can only give this diagnosis if the symptoms don't meet the full criteria for any other disorders. So you can only diagnose disorders in this category if others aren't met. So in the example that this person gave, night eating syndrome and bulimia nervosa wouldn't be able to coexist theoretically as diagnoses together, because if someone meets criteria for bulimia nervosa, then you can't give them a diagnosis of other specified eating disorder. So it may be possible to have symptoms of both night eating and bulimia nervosa together. Someone might have symptoms of both. That's, it could be present, but theoretically, you can't give the label for both at once. And like Dr. Racine mentioned in class when she was doing her guest lecture, this is kind of a problem in general for eating disorders. There's lots of diagnostic migration, there's lots of overlap in symptoms. So this could be another one of those issues. Someone might have symptoms of night eating syndrome and also bulimia nervosa, but they can't get the diagnosis for night eating syndrome because technically they do meet full criteria for bulimia nervosa, which is another disorder in the eating disorders class. Okay, that's all for now. I'm just gonna turn off the video and then wait and see if anyone has any questions, and then I'll turn it back on and we can talk about those. Okay, I'm back. So I had a question regarding differences in how individuals with antisocial personality disorder and those with just psychopathy process rewards. I'm not really sure what that's referring to, so hopefully that individual clarifies, but I think this might be what they're referring to. The Patrick, Bradley, and Long study on peer potentiated response, hopefully. So I'm just going to go over that study again and look at the results. So basically, what this study was looking at was comparing how individuals with no psychopathy, how individuals with antisocial PD, and how psychopaths process or react to pleasant, neutral, and unpleasant stimuli. So generally, when people see unpleasant images, they show an enhanced startle response. Um, and this is measured using blinking. So, what this study found is that psychopaths have a decreased startle response to unpleasant images compared to pure antisocial and also to non psychopaths. So, what this means is that they respond less strongly to unpleasant stimuli. So, where you would expect to see this large startle response to unpleasant images, psychopaths don't display this. So, this indicates that they're not emotionally aroused by disturbing things where most people would be. And I believe I actually had another question asking about the results of the study. So that was the difference between the pure antisocial and the psychopath groups, is the way that they responded to unpleasant stimuli. If you look at the graph in Dr. Weinberg's slides on this, we can see that for the non-psychopath and pure antisocial group, their responses to unpleasant stimuli are fairly similar. But then when we look at the psychopath group, you see that their blink startle response is a lot less lower for unpleasant stimuli. So that's what that study was looking at. Okay, and I'm gonna go away again until someone asks another question. Okay. I don't know if anyone is still here. I got a couple of questions that I just saw last minute, so I'm going to try to breeze through them now. One of the questions is, would you be able to please explain the final conclusion on what the ethology of PTSD is? Do you require trauma to meet criteria for PTSD? So directly experiencing the trauma is not a requirement. You can get a diagnosis of PTSD by directly experiencing the trauma. But you can also get a diagnosis of PTSD if you hear about someone who is close to you, like a close family member or a close friend, experiencing something that is very violent. So you can't get a diagnosis of PTSD from hearing that, like, your aunt just got diagnosed with cancer, because that's not like violent or unexpected. But you can theoretically get a diagnosis of PTSD if you hear that one of your friends was violently, brutally attacked, and you hear the details of that. So you can get a diagnosis that way as well. And the second part of this question was, would you please be able to explain the twin study done on PTSD with the exposed and non-combat exposed twins? So I can talk about the results really quickly. Basically, the study found no differences in total brain volume or amygdala volume between had PTSD versus where twins who had PTSD and were combat exposed versus, hang on, let me get this straight. Versus no PTSD. So it was the twins of people who had PTSD and also the twins with PTSD, they showed smaller volumes of the hippocampus. When you look at the groups where the twin was exposed to combat but they did not develop PTSD, and look at their twin, so who also was not exposed to combat or did not have PTSD, their hippocampal volumes were larger than the first group. So this basically indicates that differences in hippocampal volume, specifically a smaller hippocampal volume, is a vulnerability factor for the development of PTSD. Okay, and there was another question. Let me see if I can answer it quickly. Okay, so more MAO-A results in more degradation, lower levels of AMY neurotransmitters. There's less of the enzyme and there's less transmitters, which means there's more serotonin around. Okay, so this kind of relates to a question that I answered earlier. Let's take a look at that. Okay, so having less MAO-A means that there is less degradation of neurotransmitters like serotonin. So there's an excess of serotonin. And this is associated with things like aggression. I'm not sure what the latter part of the, last sentence show the opposite. So when Dr. Weinberg is talking about activity of MAO-A related to antisocial behaviors and maltreatment, she mentions that low MAO-A equals less degradation of serotonin, and this is associated with aggression. And when you look at the flip side, when there's high MAO-A, there's more degradation of serotonin and dopamine, etc., and this is associated with depression. So that's how the MAO-A enzyme relates to neurotransmitters. Okay, thanks for hanging out, guys. If there's any questions that I didn't get to, I can briefly answer them, and I'll post this video up soon. Good luck tomorrow. Have a good night.